Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 174th episode of the CodeCast podcast. My name is Terry Fletcher. Happy belated Valentine's Day, which is also Heart Month. So many of us are wearing red to bring awareness to good cardiovascular habits, good heart healthy habits. And if you feel any signs of concern, make sure you get checked out. We've been focusing so much on COVID this past year, as we've had to, but do not neglect your heart and other possible issues that can arise. We want to make sure that you stay healthy in the long term. So with the heart theme in mind, I wanted to give you a couple of examples of Cardiology E 2021 records that show the contrast of using time versus using medical decision-making. And you may be surprised because I see many providers now defaulting to time and using that as their leveling agent, and it's hurting your reimbursement profile. So we want to make sure that you are not only coding correctly, capturing correctly, but when you use time, it's appropriate, and when you use medical decision-making, it's also appropriate. So here are a couple of scenarios, and this is kind of just giving you an idea of making sure that you are understanding your rules as well when you're leveling your codes, because I think sometimes it's tough. And again, you know, I have that coding series, so if you need any training with the PowerPoint, feel free to go to my website, and there is one available that's current. So here is an established patient based on time. So on January 15th, an established patient presents to the cardiologist office for a follow-up appointment for hypertension. On the same date of service, the cardiologist spends 5 minutes reviewing the lab tests from a previous visit. The cardiologist spends 9 minutes with the patient, obtaining an appropriate medical history and reviewing vital signs. The cardiologist also reviews the patient's current medications, submits refills to the pharmacy, and has the patient scheduled for a follow-up visit in 3 months. The cardiologist documents the encounter in the electronic health record and only puts on there the time and said that's how they wanted to level it. Well, based on that, you've only spent 14 minutes, and so that would be a 99212 based on that code range. If it was actually on medical decision-making, it would be a 21, possibly a 213, 214 because of the presenting problem and then also the risk and the management of the patient with the prescription drug management. The scenario 2, so here's a patient seen today in follow-up to recheck a right internal carotid artery stenosis. Back last summer, the patient had a normal left internal carotid artery and 30% stenosis of the right internal carotid artery, which is asymptomatic. Today, no symptoms of TIA, CVA, or any other problems, and denies headaches. The exam was general, no acute distress, and went on to just discuss the easily palpable bilateral carotid pulses with no jugular venous dissension. Pedal pulses were normal, moves all extremities with 5-for-5 strength, no edema, and skin within normal limits. Vascular Studies, so duplex exam of right carotid artery on March 17th revealed 50 to 60% stenosis in the right internal carotid, which is increasing. Per ultrasound increased from 30 to 50 to 60%, but still asymptomatic. Physician's assessment and plan, I would like to get an MRA of the neck and see the patient back in a week to review results. So on this one, based on medical decision-making, since you're leveling this patient encounter based on MDM, you would look at levels of medical decision-making. So first of all, the number and complexity of problems addressed is low. You have one stable chronic condition. For the amount and complexity of data, the cardiologist reviewed the ultrasound and ordered a neck MRA. So the data would be limited or minimal. And then the level of risk it's really moderate because of what they're going to order and for the patient based on if the continued increase in the stenosis. But the physician would actually have to document that. So let me back up a little bit. If they didn't document the overall risk of not continuing to check this, then actually it's low. So let me just kind of give you that insight there. And that's what I've noticed too, that sometimes the physicians are not relating that risk to the tests they order, to the procedures they do. So I kind of read into that, which tells you how our minds work, especially from an auditing perspective. So if the physician didn't talk about that risk as far as getting those results, results right away to that patient because they're increasing with their stenosis, then you would be at risk as low, and that would be a 99213. And the reason is because you have to be able to level 2 out of 3 straight across, and because you have low on the problems addressed, you have limited on the data points, and then you have low on the ordering of their test results or ordering of the test, then that would be a 99213. Now, one I wanted to mention, and this one actually kind of surprised me, and I had to question the physician on this. So this one is a patient, again, established patient. They came in for chest pain, a new concern about chest pain, but it's an established patient visit, and intermittent shortness of breath. Now, the patient said in their history that the flu's been spreading at work, and some of their coworkers have been vomiting and diarrhea. Since Monday, he's been feeling tired and weak and is experiencing some GI pain and attributes this to the stomach bug everybody has, but he denies having any vomiting or diarrhea. And he denies fevers, sweats, or chills, admits the pain is spreading and includes chest pain, and he's very worried. Also, the patient tested negative for COVID. But also in the family history, father passed away in early 50s due to cardiac death, same with his sister who died with an MI at 53. And the patient does not smoke. Physical exam was limited, but discussed the cardiovascular aspects. Lungs were clear, heart RRR, but an EKG in the office shows high ST elevations, and the doctor did confirm an MI. So rescue is called to transport the patient to the hospital. The cardiologist is on call, who was on call in the ED was alerted, and EKG and patient history is provided over the telephone. Okay, total time of all this was 7 minutes, and that's how they decided to level their code. And what do you think that is? Well, if 7 minutes for the exam, 5 minutes to review the history, and 2 minutes of documenting the clinical information in the record was 14 minutes. Well, remember, a level 2 now is going to be that. So this is where you have to be kind of careful here, because when you get 10 to 19 minutes, you're at a level 2 if you're going to time your visit. But what if we looked at medical decision-making and also data points for this patient? Well, we know that the plan of care, or what we call the risk and management, was going to be high because the patient had to be basically transported to the hospital for an acute MI. But also when you are dealing with the presenting problem on that patient, what are you dealing with now? Well, you're dealing with an acute illness that poses a threat to life. So now they're basically, because of the confirmed MI. So now you have high, and then you have data points which are limited, but you have high on the patient management and overall risk. So this would have been a level 5 if it was looked at from a medical decision making instead of a level 2. So really encourage your physicians that if they're thinking that timing their visit is going to help them to hit those higher levels of service, and I'm not encouraging either way based on what you want to bill. I'm just saying that if you don't recognize that when you time your visit it could limit you on what you're doing, then that runs into some issues. Now remember, because I know it's very frustrating and very confusing, and believe me, it's been such a lesson for me and all the things that I'm reading and I'm reviewing and looking at NAMAS information as far as auditing, because we don't have clear direction from CMS on that. But remember, when we talk about the medical decision making, you can look at the data points. If you're not timing your visit, then you get to count the ordering of each test, the review of each unique test, or the independent interpretation. One of the other things on that last example, it said that the physician at the hospital was alerted. Well, that's a missed opportunity if on the time count component, if the doctor didn't spoke to that cardiologist at the hospital and put how much time they spent discussing the case. Now, I don't think it would have been enough to get to a level 5 based on what the medical decision-making did, but it definitely would have taken them out of probably a level 2 range. So don't forget those time components if that's how you're leveling, but also make sure you're understanding how to pick your medical decision-making if you are not basing it on time, where you get to count those things that you're ordering, that you're reviewing, that you're maybe doing an independent interpretation of tests from another physician, or let's say that you're reviewing some external notes from another physician or qualified healthcare professional, or labs that you did not bill for. So you always want to make sure that you are including that in your medical decision making and make it clear. One of the things I'm coming up with right now with a lot of physicians is that they're using a blanket statement, kind of like what we did with before 2021, where we said, okay, 50% or more was spent counseling. Well, in 2021, you can't use that anymore. You can use the counseling as part of your time, but we need to have more information than if you're going to time your visit than just, activities spent today counseling, face-to-face and non-face-to-face with myself and qualified healthcare providers. That doesn't do anything but give you a generic statement of nothing. You need to include some of those details as far as what is included in time. Do you have to give a list? Do you have to make sure that you have an itemized statement? No, but you do need to be able to support it. And so it's really important to make sure that if you are going to time your code, that you include some of those activities. If I see a generic statement, I don't allow it. It doesn't support the code. So as an auditor, if I would allow it, then that means I'm saying I support you if you get audited from a formal payer, and that, I can come back and help you with an appeal. I can't. So that's why when I say I wouldn't allow it, I wouldn't allow anything that I can't support too on an appeal, or if I have to go to bat for you. So make sure that you have activities included in time if you're going to use time, but make sure you're also alerting your physicians that medical decision-making could be the key based on what your patient profile is and what you end up dealing with from an overall risk and patient management perspective. But it's not just, you hit a level 4 because you gave a patient a prescription. Remember, you have to look at the information when it comes to the problems addressed at the risk table, the nature of the presenting problem. So if it's one stable chronic illness that's asymptomatic, you're in a low. So you're going to be in a level 3. Even if it's one acute, if it's an uncomplicated illness, you're going to be at low. If it's 2+ self-limiting, you're going to be low. But what if you're at 3 chronic stable illnesses, then you would be at moderate. So you need to know what the patient's presenting for. To get to high, it's tough. Severe exacerbation is really what you're looking at, or an acute illness that's a threat to life. And so it's important that your physicians acknowledge that when the patient's coming in for their encounter, or even on telehealth, so that you can support it. Okay, so let's look at a coding question today. And I thought this was an interesting one. Again, just sticking with the Heart Month cardiology specialty. So Terry, can you help me find the correct code for a 6-lead ECG home visit? My cardiologist performs home visits for most of her homebound patients. She carries a portable ECG device with her at all times, and she performed the test and interpretation with a report and a strip, and as documented in the patient's chart. So what you're looking at here, this is not your typical ECG, EKG. What your provider is most likely using is what is called a Cardia mobile device. This device is the first ever FDA cleared mobile 6-lead ECG. The patient's ECG is recorded and then available to be downloaded and interpreted. And you're supposed to use the 99091, and that is called the collection and interpretation of physiological data. For example, ECG, blood pressure, glucose monitoring. And it's digitally stored or transmitted by the patient or caregiver to the physician or other qualified healthcare professional, and then qualified by educating, training, and licensure regulation. That's the FDA part. So make sure that you are noting what type of device in the patient record so that you can get that billed and paid for. Also make sure this requires a minimum of 30 minutes of time each 30 days. So if they haven't spent that kind of time, then you may not be able to report it till you hit that 30-minute threshold. Now, another question came up, so you get a bonus today of 2 coding questions, and it's kind of coding, but it's a question that's been coming up quite a lot for me, and it basically said, Terry, I listened to a webinar that you gave recently, and you said that even though we should prepare for ICD-11 now, or at least in the near future, it may not be on its way. What is the actual timetable for that? So ICD-10 revisions continued this year with the addition, as we know, of Chapter 22 codes for special purposes, so the U code section. And we got some new codes for vaping-related disorders, UO 7.0 for COVID-19, UO 7.1. But the timetable to transition to ICD-11 in the United States is still unclear. The World Health Organization approved the code set in May of 2019 for implementation on January 2022, but the code set wasn't for clinical modification. It was for PCS, which is the procedural services, and that's for the hospital. And so most coding professionals that I've talked to don't believe it'll be ready until at least 2025 when it comes to the CM version. Maybe even 2027. So just know that ICD-11 is far off for professional billing. So for right now, just make sure that you're aware that it is kind of on, I don't want to say on hold, but they're doing everything they can to try and prepare for it. Just to keep updated on it, if I haven't mentioned it in a while, make sure that you're looking at the National Committee on Vital and Health Statistics website. It's ncvhs.hhs.gov/, and just check on it occasionally to see if the updates are there. So it should be, but just make sure that you're always checking on that. Our coding question is brought to you today by Harmony Healthcare. We deliver expert consultants within population health and reimbursement to providers on a national basis and across all healthcare settings. harmony.solutions.com. Okay, so personal tidbits today. It's been great. We've had some fun celebrations in my family. Actually, I'm recording on a day where it's my daughter's birthday, so shout out to Summer. Happy birthday. And also, I'm just really happy to see the decline in the COVID-related deaths, and we have now more vaccines that have been given out than positive tests over the last 3 weeks, 21 days. And so hopefully we're seeing a light at the end of the tunnel. Now, I saw something today that was interesting. It said South Korea's capital city is now offering free COVID-19 testing for dogs. Now, we all love our pets, but can we get the humans tested first, please? And just really try and, let's see what we can do to get through all of this. So that kind of gave me a little bit of pause. I understand it, but, we've found that it's 0.00004% that a pet can contact COVID. So let's really kind of focus on our human testing if we need to. So anyway, that was just kind of strange for me. But anyway, so we hope everyone is out there really trying to get outside. Hopefully you're not buried in the snow. Also, our hearts go out to the terrible accident that we saw happening over the last week in Houston on the highway, that, multiple car and semi-truck pile up. I'm so sorry to those families. So hopefully they're okay and they're healing. And I'm so sorry to see that. That was just heartbreaking, and it was terrible. Now with the NFL done for the season, we know, of course, Tom Brady won his 7th Super Bowl ring. So what is it that I watch now? Well, actually, I am a Pittsburgh Penguins fan for hockey, and I know this sounds weird, but yes, I do watch UFC fights. So I think it just gets out my aggressions on TV. And so, yep, tonight is a fight night that I am watching something for that. But anyway, hopefully you're finding something to distract you, just to kind of get your mind off of everything work, mind off of whatever the distressing news is out there, and just to hopefully get a little bit of a mind vacation. If there's nothing else that you can do, just stare outside for a little bit. I know we all need it, and we all need that break. So everyone, make it a great week and a great rest of your day. And thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.